Hi, everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Boutwell, CEO at Envello Medical.
And I'm Dan Rodenhaver, the Chief Commercial Officer at Envello Medical. And today we're joined by Dr. Babar Basir, who is the Medical Director of Acute Mechanical Circulatory Support and the Associate Program Director for the Interventional Cardiology Fellowship Program at Henry Ford Hospital in Detroit. Dr. Basir, great to have you on the podcast today.
Thanks for having me.
We started this podcast several months ago, and we've had several guests on, and we talk about really all things perfusion. We've learned a lot in cardiology over the last couple of years as we've gotten into the our company is evolving and looking at this market as an opportunity for some of our technology. But we really want to learn more about the needs in cardiology, specifically as it relates to hemodynamics and the challenges that we see.
Yes, one of the things we've really been thinking about frequently in our conversations with you is limb ischemia, and really what limb ischemia is, how much limb ischemia is okay, what the differences between chronic limb ischemia and acute limb ischemia. Can you talk us through that a little bit and sort of how you conceptualize limb ischemia and how you manage it right now?
Yeah, so I mean, I think limb ischemia is common, particularly in states like cardiogenic shock. It can be for a variety of reasons. So we use vasopressors, for example, pretty regularly in patients who are in cardiogenic shock, typically over 80% of the time. And in those cases, what we're essentially doing is shifting blood away from the periphery into the central circulation to provide perfusion to the end organs. And when we do that, we at risk of developing ischemia within the peripheral space. And patients who have cardiogenic shock typically have other risk factors for heart disease and peripheral arterial disease, and so it becomes common. The other aspect is that, there's a growth in the use of hemodynamic support devices for the stabilization of patients who have cardiogenic shock as well. These tend to be larger devices. The smallest device we have is a balloon pump. It's about 8 French. We use an Impella that's around 14 French in the periphery, and then it can be placed by a surgical cut down as well. And then we use ECMO cannulas, which can be anywhere from 15 to 19 French as well. And so these devices are large bore devices that have a significant impact on limb perfusion. And they can block perfusion down a limb, causing acute limb ischemia, which is really a catastrophic event, because if you have cardiogenic shock complicated by limb ischemia, I will say the vast majority of those patients unfortunately pass away.
Actually, I want to go back to something we've talked to you before about acute limb ischemia, and I want to get to that in a second. But something I hadn't really appreciated in the past is that there's limb ischemia just in the cardiogenic shock patient as we use directed therapies. So, can that be dangerous for the limbs as well, or is that just sort of a symptom of the use of these therapies?
Well, it can be. And luckily for us in general, the limbs have always been forgiving to us, right? Unlike the kidneys or the liver and other end organs. And so, we just do what we have to do to be able to kind of help improve perfusion to the end organs in that setting. But that being said, at very high doses of vasopressors, we've seen patients who have gotten amputations, for example, and not just in cardiogenic shock, but in severe septic shock as well. And so those, it's an important complication to keep in mind. And it's really important to just make sure that we do everything that we can to prevent those complications.
Are there patients who have, you mentioned the comorbidities, and the patients who maybe have like a higher baseline of ischemic disease in the peripheral tissue already, like it's more of a baseline chronic limb ischemia? Are those patients, do they have more compensatory mechanisms built up and make them more resilient to development of acute limb ischemia in surgical settings? Or is it really just we have this risk that's sort of across all populations?
Well, I think point is important, Casey, is that, there's two aspects to this. One is that, chronic limb ischemia, you develop collaterals and some ischemic preconditioning. And so as a whole, that may be, helpful in that those compensatory mechanisms are there. But unfortunately, when you develop cardiogenic shock in particular, and you're decreasing blood flow to the extremities, most of the time, it's not very beneficial. And in fact, these patients are just at the highest risk of developing acute limb ischemia. And because they don't have a reserve in place, essentially, because their compensatory mechanisms are already being built up because of whatever kind of a collateral flow that they have, it becomes really, really problematic to be able to help these patients. And that's with any therapy, unfortunately.
Right. That makes sense. It would be sort of perverse for CLI to be protective against AL.
Yeah.
So I say we should go develop CLI. How do you manage this in the hospital now, or how do you? I mean, some of these interventions are not long-term interventions, and so some ischemia is okay, right? Like as you said, limbs have been sort of forgiving. How do you figure out how much ischemia is all right? What sort of clinical intuition do you use, and how do you train new doctors to manage that?
Yeah, it's actually really tough. We're not good at it right now, to be honest with you, right? And I don't think we've ever been able to establish a threshold between when something becomes really problematic and severe and potentially unable to be altering, right? And so I think what we're doing right now is we're just monitoring these patients actually. And so that can become from lab tests like CPKs, for example, where we're looking at muscle necrosis to be able to help define whether we're doing an okay job or not. We're using Dopplers, for example, pretty regularly to be able to monitor that there's perfusion to the lower or any of the extremities as these patients are being treated. I think all of that is exacerbated when they have a hemodynamic support device, where we know the risks are a lot higher. So there are protocols in place to check pulses, at least in our hospital, every hour in certain patients. And then there's this, whole field that's growing of being able to actually do tissue oximetry and monitoring of limbs to be able to help prevent this catastrophic complication as well.
Or maybe at least see it coming.
Yeah. So you were co-author on a paper last year that I saw that discussed long-term effects or effects of long-term hemodynamic support past high-risk or in high-risk PCI patients. I presumably keeping a MCS device in after the PCI. And it seemed like those patients may not have done as well, or so why do we do that? I understand that we use like the Impella during PCI, but why sometimes is it kept in quite a bit longer?
Yeah, so I think it's important to just keep two things in mind, Dan, is that so there's two major fields in the interventional space where we use support devices. One is elective PCI, and then one is cardiogenic shock, right? And it can be associated with revascularization in PCI or without it as well. In the first example, and that's the paper that you were mentioning, what we demonstrated were that there were certain risk factors that were associated with the inability to wean the support in the index procedure, like the day that we're fixing the blockages, and that we would leave that device in, for example, overnight. And, these are typically patients with hemodynamic changes during the procedure that we've been monitoring that are at higher risk of, crashing basically without the support device. And so we leave it typically just overnight. And so, yes, those patients are inherently higher risk than those patients who were able to take the device out on. But in general, they're still within the group that generally does well. Lot different than the cardiogenic shock group, who are typically leaving the device in for a couple of days in the hope that they start to reverse out of their shock and then have hopefully some LV recovery.
So how much is too much? So how long, if a couple of days or a day leaving a device in is comes with some extra risk? Some of these patients in the cardiogenic shock patient population, it could be in for a while. But how do we know how much is too much? When do we determine ischemia or any other type of complications too much?
Well, I think it's it's really dependent upon the patient, right? I mean, so we can keep support devices in for weeks to months, and not and do okay, but there's always an inherent risk of anything happening. So a good example, for example, is an axillary cut down in the subclavian with an Impella 5.5, where you can use that device for a longer period of time. But at any point, you have a foreign body there. You could develop a thrombus, for example, in the axillary, leading to acute limb ischemia that would need to be intervened upon, and essentially immediately. But then there are also those patients who never develop that. It can go on for long periods of time. So I think it's really challenging to be able to identify when is, when it, by length of stay or by length of a device, that when is the cutoff to be able to say that the risk is too much. But what we know is that the longer you keep a device in, the more complications that are there. The most important thing that I think we should also appreciate is that when you've identified that you have limb ischemia, now that's when the clock starts, right? And that's where within a few hour window, I definitely less than 4 to 6 hours, you need to change the trajectory of that patient. And that may mean swapping a device out. That may mean, doing some kind of peripheral intervention or surgical intervention. But that's where the time becomes really important, because, as I mentioned, if you have acute limb ischemia and cardiogenic shock, for example, on a patient, your mortality rate, by some observational data that we have, is over 80 to 90%.
You talked about interventions and how catching things late makes more severe interventions, and the longer that implanted devices are in place, the longer that risk profile, the patient is exposed to that risk profile. And I imagine that even if we can't objectively measure perfusion, we can get a sense of not too much ischemia means, all right, patient probably recovers. Too much ischemia means limb is removed. What are the stages in between, and how does that affect, like, maybe is there a chronic pain? Is there a chronic pins and needles? How does that affect sort of quality of life years, and how do that diversity of patient outcomes affect costs later for the health system?
Yeah, Casey, it's so hard because I'll be honest, we're really bad at detecting it in the first place. That I think that's the fundamental problem is that, we look for pulses, we look for our physical examination of, I'm just going to use the example of the lower extremities, that if they're dusky, right? Like, but I'll be honest with you, dusky limbs, there are some people who have that at baseline because of their peripheral arterial disease. There are certain patients, who develop that because of the support devices in, and they're actually having limb ischemia. And unfortunately, we're looking for changes that already demonstrate that there's a lack of blood flow to those organs, because we're looking for muscle rigidity. We're looking for, a patient developing numbness and other symptoms, for example, if they're awake. Many of these patients are, in comatose states or with sedation. And so they're not even able to tell us. And so we're relying on ourselves to be able to identify them. And again, an absence of pulse clearly is an emergency, and everything needs to be done to restore that pulse if it's not there. But what about the patient that does have a pulse, who is slowly getting worse and worse, and we're not even able to really be able to tell it up until there's a problem? And, when there is a problem, we know that it does lead to repeat interventions, and clearly it is very costly for the healthcare system to deal with.
almost like we need a pre-shock, like we talk about pre-shock and cardiogenic shock, whatever that means. We need like a pre-ALI in the lymphofusion space.
Yeah, absolutely. I mean, something to be able to let us know that things are getting worse. So it's some of the things like for example, getting a pulse that's an on and off. Like you have it or you don't have it, right? And so that's one mechanism. But having some kind of a grading scale will be helpful other than physical examination, because the problem with physical examination is that it varies. And we have to be realistic is that in the ICU settings in particular, it's not just nurses that are doing shift work, even physicians are doing shift work. So you on any given day, you may have a different doctor taking care of you. And, an examination on one day doesn't necessarily mean the same examination on the other.
So let's talk about something, the future and something positive. So you get involved in a lot of, research and you see what's going on out there. What are we looking for? What are you looking for? What do you think are the best ways to approach some of these challenges? And what do you see on the horizon that might be helpful in this situation?
Yeah, so it's I think there's so much work to be done here. I think we're really scratching the surface on being able to improve our outcomes. I mean, we spent a decade trying to just be able to prove to that what we were seeing in Detroit and in the National Cardiogenic Shock Initiative with the use of Envello was helpful in AMI shock. There's still all of heart failure shock. There's out of hospital shock that's poorly recognized, and this is all in resource heavy environments in the United States and Europe, let alone what the impact is of these disease states in other countries where the resources are more limited and scarce. So I think there's lots of different things to potentially be able to do. I think what we really want to try to be able to achieve, and the goal of I think all shock programs, is to improve early recognition, right? To be able to tell sooner that patients are developing cardiogenic shock or a hypoperfused state, so that we have the ability to change that trajectory early before we talk about using any devices and any of those kinds of things, right? And so that's where I think, wearable technologies, perfusion technologies are going to be really interesting. And, I think it has a really potential opportunity to change the field, especially if it's, a cost-effective method and that's easy to use and to wear. Then you can kind of slap a probe on somebody, be able to kind of assess objectively, again, where they are in a kind of a hypoperfused state. And again, that early recognition can trigger so many other ways for us to help patients before we're talking about the more riskier, higher cost devices.
Yeah, this is great. We sort of booked a short period of time with you. There's so much we could talk about. We've started to get to know you a little bit over the last 6 or 9 months or so. So we really appreciate you coming on with us today and discussing this. We learn from you and from your colleagues all the time. And with Perfusion Musings here, we're trying to do our part to just get more of this information out there, because we agree from what we hear there's a lot of work that Envello's doing, but so many other smart, innovative people are doing to try to advance the field. So your perspective is always great for us. So thanks a lot for joining us today.
Oh, awesome. Thanks for having me. I appreciate you guys. Keep up the hard work.